5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi, and welcome to Diary of a Kidney Warrior podcast. My name is Dee Moore, and I am a Stage 4 Kidney Warrior. This podcast is dedicated to encourage, educate, and inspire as we explore all aspects of kidney disease, chronic illnesses, and health. If you have any questions or ideas for topics you would like me to cover, please get in contact with me on social media using the handle Diary of a Kidney Warrior. In today's episode, returning to answer your transplant questions is consultant transplant surgeon Dr Frank Dor. Hi and welcome to Diary of a Kidney Warrior, the podcast. How are you doing today, Dr. Frank?
Yeah, I'm doing very well. Thank you. Excited to be back.
I am absolutely buzzing to have you back. Honestly, it is a real honor to be able to interview you today. For those of you who are new to the podcast, this is actually my second interview with Dr. Frank. The first interview was episode 21 of the podcast. Please do check that out, where Dr. Frank and I looked at questions that were sent in by podcast listeners. And there's lots of information there that you can refer back to. But this episode is actually the first under the partnership with Kidney Care UK. So I'm doubly excited to be interviewing you today. So thank you again for your time.
Pleasure. And congratulations to both of you, Kidney Care UK, for having you on board and you for being part of that wonderful organization. So it really is a win-win situation.
Oh, thank you. So we've got some really, really good questions that have been submitted by the podcast listeners. And the first question comes from Rachel. Rachel asks, is research underway to check efficiency of COVID-19 vaccine in transplant patients?
Yeah, this, of course, is what everyone wants to know. I'm delighted, actually. There's lots and lots of research going on in many centers in the UK, but also in the rest of the world, because this question has been bothering us since the beginning of the pandemic. How would the COVID affect transplant patients? And then the vaccines became available. How successful would the vaccines be in transplant patients and in transplant waitlisted patients and kidney patients in general? So I know there's a very recent outcome report of a big registry research project done here in the UK that was linked with the COVID vaccination database and also the COVID registry, showing that now, up to the 24th of June, I believe it is, 80% of all transplant patients and transplant waitlisted patients, so this is beyond kidney only, have had 2 doses of the vaccine. So 80% in the UK, which is good, but you could still see room for improvement there. In London, the uptake was a little bit lower, unfortunately, so 75% compared to 80%. And certain groups, unfortunately, the uptake was less, so 65% to 75% in Black, Asian, and other minority ethnicities, as it's officially called, BAME population. So again, room for improvement, but that's just how many people were vaccinated fully. If you compare people that had no vaccine at all, and that is 6,700, 7% of them, so 466, unfortunately got COVID. And this is key here. From these people who were not vaccinated and got COVID, 40% unfortunately died. So this is really high. That we're talking about 189 people that died within 28 days after a COVID positive test. Now watch this carefully, because 39,000 transplant patients that did get fully vaccinated, less than 1% got COVID. So this is a handful of patients. It's 76 that got COVID. And only, well, it's always too many, of course, but only 6 of them died. So that's 8%. So there's a huge difference in mortality, as we say, so the number of patients that died that were vaccinated versus non-vaccinated. So this shows vaccine is working, even in transplant patients who receive immunosuppression. And also, if you look at the wait-listed patients, the same trend is seen. So we had 650 wait-listed patients who didn't get vaccinated. 8% got COVID, so 51 patients. 17% died. So that's less than the transplant patients, but still, an awful lot of people. In this case, 8 people in total of that cohort, but it's still a high percentage. 3,100 patients that were on the transplant wait list but had a vaccination, again, less than 1% got COVID, and no one died of these 650. So for me, this is very strong data. And of course, this gives a lot of reassurance that we should keep going with the vaccines. The biggest point, of course, that we still need to determine is what is the best readout. So how can we determine if you've had your 2 doses, if you're fully protected or not on an individual level? Because, we can test what your titer of antibodies is that has been generated by giving the vaccine. So basically, what's your antibody level? But that's not the only thing that's important. And also, because you can just test basically the how many antibodies you have, but it doesn't say anything about their functionality. So I could have thousands, a very high titer of antibodies in my blood after my vaccines, but my response might actually be equally good to someone who has a lower level of antibodies. And antibodies is only one part of the equation. The virus gets killed by activating highly educated T lymphocytes. So those are specific white cells that are often reduced in number, but predominantly basically suppressed by immunosuppressive medication to prevent rejection in transplant patients. These T lymphocytes are very important players as well, and there's lots of research going on to see if levels of T lymphocytes or the functionality thereof can predict your individual response to COVID because of the vaccine. So it could be that I'm 100% sure that in the next year or so, we are learning what the best readout is to say I have a good efficacy on my vaccine. And also we might be able to, on an individual level, predict sort of if that's good enough for you and if you're fully protected. Now, of course, it becomes more difficult because with all the mutations of the COVID virus itself, it might be that at some point we're going to see a variant of the virus that might not, that might escape basically the antibodies or the T lymphocytes that we generated because of the earlier vaccines. This is nothing new. This is the same for the regular flu. That's why, everyone has to have their regular flu vaccinations every year because new variants will pop up. I'm sure they will. And we have seen it already a couple of times here in the UK. Now, so far, thankfully, we see rising incidence of COVID infections in the UK, but it looks like, so far at least, and thankfully, that the numbers of hospitalizations, ITU admissions, and patient death are very, very low compared to the previous waves. So I'm optimistic, but research is still needed to continue at full speed and with all the support we can get. And thankfully, lots of transplant patients and kidney patients in general are so immensely fantastic by participating to all these research projects and making sure that we learn as quickly as possible how we can protect you as patients to the max we can. Now, I know, for example, I think this will happen as well, is that, for example, other countries are giving a third vaccine, a booster, basically, to transplant patients and other immunosuppressed patients. This is something that I think is being considered at the moment in the UK as well for specific vulnerable groups. And this might be based on low antibody responses after vaccine or just in general. I think the jury is not out there yet, but I think we can expect transplant patients to qualify for third vaccines soon-ish in the UK. I think I should stop there because we can talk about COVID and the vaccines for hours alone. But this is I think the biggest breaking news from actual UK data.
So Rachel goes on to ask, is there a plan if the vaccine is not working and we begin to see breakthrough cases in double-dose transplant patients?
Yeah, I think the plan is there for, firstly, consider the third vaccine, so basically the booster that I was just talking about. And there's so much developmental work in vaccine world happening that I'm sure that people are already anticipating to creating vaccines with different mechanisms to induce immunity against the virus. And I think this started sooner before we actually thought about it, I'm sure. Because luckily we can say that from everything COVID related, science has really, really been developed quickly and fast and joined up and collaboratively. And this is one of the massive gains of the whole pandemic, I think, that there was transparency, there was quick publication, quick sharing of results. So I'm sure these anticipatory next steps are already in development, should everything fail. But having said that, we have now seen, I've just shared with you the data and the figures. I hope it's sort of understandable because you can't really see it, of course, but the massive reduction in deaths after COVID infections in transplant patients because of the vaccine is the strongest that we have seen so far. So this is really robust and high quality data.
So I have a question from Nicola, which is also related to the COVID vaccination. And she's asking in terms of immunosuppressed people. And she's asking, if you were in the same position, how would you go about keeping safe while the country is gearing up to open up and end legal restrictions such as mask wearing and social distancing?
Yeah, of course, this is a daily question and it's very interesting. And thank you for asking it to me directly. I think this is what we as doctors in general should do all the time. Basically, what would I do or what would I recommend my mother or my loved one to do in this situation? Because then you properly think about it. First of all, I do, and this is not to because you are now linked with Kidney Care UK, but throughout the pandemic, I have recommended patients to follow government advice through Kidney Care UK advice because amazingly, and thank you so much for all involved, this has been the key information, I think, for our patient cohort. So all kidney patients, all kidney transplanted patients as well, I advise them to go to the Kidney Care UK website to see what the latest government advice is. Because sometimes I, just because of busyness at work, cannot see all the details for this patient group alone. And you just want to make sure there is a central point that gives out the most accurate information. What I would do at the moment, I think very clear, I will have been fully vaccinated because the benefits of the vaccine, even before the data, official data came out that I just mentioned, it makes so much sense to be fully vaccinated in order to reduce your risk should you get COVID. Because this is the key, of course. Being vaccinated doesn't mean that you can't get COVID. It's less likely to become, you can still get infected. But what happens after the infection? Do you get ill from it? And do you get severely ill from it? Or would you even die from it? I think that risk reduction is massive. So I'm assuming I would be fully vaccinated. Actually, I would educate other patients about the benefits of the vaccine, even though there are some risks. And of course, some people, unfortunately, have had complications because of the vaccine. But if you compare that in numbers and figures scientifically, it is no comparison at all. But of course, if your loved one develops complications of a vaccine, this is 100,000% happening to you so this is all you hear, all you read. And also the way information is delivered to you in your personal information network is highly dependent as to what your personal interests are. This is also the intelligent design of, for example, social media. If you always search COVID vaccine complications, somehow there is intelligence behind Google and all other media that you're more likely to receive information spontaneously about complications of COVID-19 vaccines. Whereas if you are completely looking for opposite information, the intelligence behind it will make sure that you get different information. So this is very, very important to realize. So what would I do? I would try to educate other patients. I would make sure that my household was completely vaccinated in order to reduce all of our risks, but especially as a patient, I would be quite keen that others would be considerate. And I'm 100% sure that most of the people who live as a family or live in sort of co-living households would be considerate of someone who is more vulnerable. Out on the street, obviously, I think the key is to keep protecting yourself. So all the general advice about hygiene, about wearing masks, even though that other people might not be doing it, you can still protect yourself. Also, it's very difficult, of course, as a patient, because all patients have been isolating for such a long time. And I've seen people suffering. People actually still are scared to come to the hospital to see me in the probably most safe environment at the moment that you can imagine, and how we have kept everyone safe in the hospital and developed pathways in outpatients to check everyone at the door. This is still happening. So even though the government advice for the general population is becoming more liberal, this is, I think, also important for many, many people as well. We still have very strict pathways in the hospital, outpatients, inpatients. So, for example, still no visitors are allowed on the ward, only with exceptions, and things like that. So I would really try to adhere to the max to all the protective equipment you have. But also, I think for sanity and for psychosocial well-being, it's good also to go out a little bit more. And by having had the vaccines, I think you will be slowly able to relax a little bit. I'm not saying we should not be vigilant anymore, but also the feeling of going out for the very first time again in a controlled environment and meeting people again is an absolute necessity for the psychosocial well-being and the sanity of every individual person. We need people. We need to see people. So I won't say don't isolate, but I think try, based on the data as well that we've seen, that vaccinated people have less chance of getting ill from COVID and die from COVID. There is a little bit more room for optimism. And again, follow the advice of Kidney Care UK on the website, because it's always up to date through social channels. So if you keep one reliable source of information, I think it's most important, rather than trying to find all kinds of misinformation, or a very popular term, of course, fake news, which is all over the place and can actually drive you completely crazy. I can not even imagine, how insecure people have felt, how unsafe people have felt, and how much people have suffered because of this. So at some point, because I always try, to participate in patient education on social media, for example, and so there was some data, of course, that in the beginning that some of the vaccinations didn't really work for all transplant patients. And we share that on social media, and some healthcare professionals feel it their duty to do that and inform the patients to the best we can. But I actually got an anonymous letter from a patient, probably not necessarily one of my patients, but saying how angry he was that I was condemning them to more self-isolation and more insecurity by just sharing information. Obviously, this is not the intention. The intention is always to be my job, and beyond my job, it's my personal belief that it is my duty to inform everyone with the right information as far as we have, and make sure that we're not condemning people to self-isolate and to try to destroy patients' lives. Not at all. It's the opposite. So I was quite upset and disappointed, actually, that people feel that way. But it also made me realize that, of course, social media is great and very powerful in sharing the latest news and the latest scientific developments, but it also has to be translated into, into piecemeal for most of the people and patients not in the field. And for me to realize what an impact only one tweet can have in someone's life. So very cognizant about all that. And that's why my answer takes, it feels like an hour, but at least I try to bring it all together here and hope this gives a bit of a view as to what I would do as a patient and my family and my friends, and keep explaining also that you are a bit more vulnerable or much more vulnerable than others, and people will have consideration. I'm only hoping that after all we've been through together, that people will understand that whenever they are close to you, to please put on that mask and to please be considerate with some extra hand alcohol and hygiene in general. And, I can only hope. But I'm optimistic. So that's the other side of the coin. I'm really optimistic.
Thank you. The next question comes from Belina, and she said, I have recently lost my kidney function and have started peritoneal dialysis and have been placed on the kidney transplant list. My question for Dr. Frank is, I'm a black woman and I wondered if I can only receive a transplant from a black donor. Is it possible to also ask how long that might be, if that's the case or not?
Yeah, this is a very important question, actually, because it surprised me a little bit that apparently, people might still be wondering this. The beauty of transplantation is that it goes beyond color of the skin, it goes beyond ethnicity, it goes beyond religion and any other discriminatory factors that distinguishes human beings. It's about people. So that's the first principle, is that it should be accessible to everyone, independent of where they come from all these factors I just mentioned. So the answer is very simple: no. Everyone who's on the kidney transplant waiting list could have an organ of someone from the same ethnicity, but quite often this is not the case. And also, to just let you know, when I'm on call and I receive an organ offer for a patient of ours, we don't even know the ethnicity or the religion or the skin color. It's not relevant. It is only relevant that there is a donor organ available for one of our patients, and therefore this will be always considered to the fullest if this is a suitable organ donor for that patient. There is, of course, I think I understand where this comes from, and that's why it's good that it was brought up, that certain communities in the UK, and this is not only in the UK, this is everywhere in the world, that some patients from certain communities have more difficult access to transplantation waitlisting or to a live donor transplant compared to other ethnicities or people with a different culture. And this is not because of the skin color or the ethnicity. This is a very complex situation that lots of people in the UK and beyond are doing many research projects to try to improve that. But we know indeed there is some difference in terms of access to transplantation, but this is true for healthcare in general. And we have seen that in COVID, of course, as well, that it was clear that healthcare access is there for everyone, and it should be the same for everyone. But still, some people from certain groups will have more difficulties in finding their opportunities compared to others. And as a white Dutch man in the UK, I'm slightly worried that this is true for the white Anglo-Saxon people. That access seems to be a bit more easy to certain parts of treatment and treatments in the NHS, including transplant. So the key is we really have to work with people and patients and using experts to making sure that how do you show success? How did people end up being transplanted from several communities? Because if we always only see, say, people from Asia talking about transplantation, it might not resonate very well with people that have a different ethnicity and have a different culture, use different words, or use different non-verbal communication. It's very important, and we've seen a few good examples. Also, I think in your podcast, you have had a few good examples of people working as patients or as patients advocates to show how particular community peer educators could help. Lots of research also implies working with religious leaders to see how they can play a role in their communities to activate patients. Because we do know it's not just ethnicity that determines healthcare access, it is also socioeconomic status, perhaps even more important than ethnicity, to be honest. How can we activate patients to use their opportunities to learn at their individual, in their individual language, and I'm not talking about a different language than English, but you know probably what I mean. It's everyone needs to be addressed in a different way, and I try to apply that in every clinic I do. So irrespective of culture or religion or skin color, you always need to see who is in front of you and how can you address that person's needs. And in order to get there, you need to just find a few, through a few very simple questions, can already tell you, what do you do in life? Where do you live? What is your social status in terms of, do you have a partner? Do you have children? It makes a difference. And with a few questions, you find out what their interests are. And therefore also that determines how I would address people. So it's the same message, but delivered in a different way. So I think in general in the NHS, lots of people are fully aware that we need to, be a bit more tailor-made and address these things in order to, find ways for people to find their way through the NHS and get optimal access to their healthcare needs.
Thank you. The next question comes from Donnie. And Donnie asks, I'm a potential future recipient and was wondering if you could ask whether Dr. Frank listens to music at work. Would be interesting to find out.
Yeah, fantastic question. And the answer is simply yes. And I think most surgeons these days will listen to music during operations. For me personally, I love music. Music is with me for decades and decades, or I'm sure since the beginning of my life. I've been a clarinetist, so I played music myself in orchestras and ensembles, and I enjoyed that a lot. And also, I've been a choir conductor and a choir singer. Also in London with the Fulham Camerata, in case someone listens. And we have not been able to sing. So I sing a lot during operating as well. So when I sing, there's no music on. And unfortunately, sometimes when I sing, people start putting music on. So I'm not sure if everyone appreciates it. But no, I have had a decent training in music. And my wife is a musician. She's a harpist. So music is everywhere, and music is always in my head. But since it's such a fun question, it's also good to have a little bit of fun during such a podcast. We quite often even, try to find a song which is applicable to that particular surgical situation. and then we try to change the words of the song and sing it all together. And I encourage everyone to sing. And it's interesting because it's so important in what kind of atmosphere you work as a team, because it's not just about me. Because in the old days, if I wanted to listen to opera, I could listen to opera, but no one else got to decide. I think it's important that you work as a team. I might be the end responsible person in the night or in the morning or in the evening, but it's not just me who determines which music is going to be put on. So quite often we make someone the DJ of the operation, and they can choose what to play. And I love so many different music styles, from classic to techno house music, from jazz to hip hop. You can name it, and music is just great. There are some situations. So, for example, I think you should not be distracted by music. So, if there's crucial phases in the operation where things are really difficult, because music is, I can't just listen to music in the background. Music does come into me. So I think when something is really difficult and I have to do really crucial steps, then sometimes I ask for the music to be switched off or not to play at all if you can anticipate that it's difficult. But it helps in general creating an atmosphere where everyone is relaxed, not distracted, but relaxed. Tension in theaters, whenever everyone is dead silent and doesn't dare to speak, can be extremely counterproductive. So I like good atmosphere in theaters, and I think that's good for the patient. Just to come back, because I remember one time, this was in the Netherlands, I sometimes ask my patients, do you want to listen to music or when you go to sleep in the anesthetic room? Or one patient had a request for me to play a CD. And this was Mozart Piano Concerto number 23. And that was their favorite. Now, I know all of these piano concertos by heart, every single note of them. So they gave the CD and they started playing, and I was completely upset because it wasn't Piano Concerto number 23, it was 21. So I think the patient was trying to test my knowledge on the piano concertos, but we played it regardless because it's a beautiful piece. But also we can play dance music or whatever, as long as it doesn't hamper patient safety, of course. But some of my colleagues, and for example, Mr. Jeremy Crane, one of my colleagues, he developed a playlist on Spotify for music in theaters. And it's a very popular topic. There were Twitter polls and what is your favorite song during operating and things like that. So it is a real thing, music and operating. And there's lots of research even that playing music in theaters or playing music with the patient on their headphones, even on the general anesthetic, can give them sort of less distress and better outcomes. So there is something with music and surgeons, but also music and patients. I'll leave it there. That
is incredible. I honestly, because I love music. I'm a singer, as you may know.
Yeah, I know.
And so, to hear that even under general anesthetic, that it has therapeutic benefits, that's fascinating. That's really cool.
So don't ask me for next time to sing a duet, right? But in the next podcast.
Okay, I'll make sure I won't do that. The next question was inspired by Mark, and this question is, how does a surgeon decide where you position the kidney transplant?
So we're going back to surgical technical stuff. Thanks, Mark. This is an important question because many people actually ask me, so where do you always take my own kidneys out, for example, and then put the kidney transplant on the place where one of my own kidneys was sitting? And where else can you put a kidney? So basically, normally, there is no reason to remove any of the native kidneys. So basically, your own kidneys that are no longer working if you need a transplant. This is just to minimize any potential risk of doing that. So if there's no need to take them out, you shall not take them out. There's a few exceptions. Of course, if there's kidneys that are so large because of polycystic kidney disease, so large that they weigh up to 10 kilos or more each, and they can occupy the whole abdomen, and it can actually cause for people to look pregnant for 20 months. And in those cases, there's basically no space to put even a kidney transplant in the regular spot, and then we might have to take them out. And of course, if there's a kidney cancer, a native kidney will have to come out, and you have to be cancer-free at the time you get transplanted, or shortly thereafter. We might have to remove one of your own kidneys, and that is all decided by multidisciplinary teams how to approach that in case of kidney cancer. But in general, your own kidneys stay in place. Also, so normally a kidney transplant goes, as we call, in the iliac fossa. This is a space that normally doesn't exist. It's basically, if you look at it on your own abdomen, it's the lower part of your abdomen, just above the groin. Why is that we put it there? We need good blood vessels to connect the kidney blood vessels onto. And also we want to be close to the bladder, because the urinary tube, the ureter of the kidney graft, will have to be connected to the bladder to make sure that all the urine that the kidney is hopefully making, the transplanted kidney is hopefully making very soon, will be transported into the bladder. So this is the principle. So in general, we use this iliac fossa, and we sew the kidney transplant arteries and veins onto the iliac arteries and veins of the patient, and the ureter onto the bladder. Now, of course, it could be that, for example, a patient has very bad atherosclerosis. So there could be lots of chalk in the blood pipes. And if there's chalk in the blood pipes, calcifications, it could be rock hard. And there is no way that we can place clamps to close the blood pipe where we have to interrupt the blood flow briefly to connect the kidney graft blood pipes to, and let alone that we come with a very fine thread to do the sewing part with. You can't even get a needle through rock. I mean, this makes sense. So it sometimes is not possible to do it at the ideal spot. And the ideal spot is the iliac fossa. So sometimes you have to go slightly higher up on the same arteries, but closer, higher up in the abdomen. Sometimes you even have to do it, as we call it, intra-abdominally. So we have to then open up the abdomen in the midline and do the kidney transplant high up in the blood vessels. This could be because of the vascular situation, or it could be that you've had previous transplants that were, originally in the ideal spot in the iliac fossa. But if there are already 2 transplants there, you can either take them out, which we normally, most of us don't prefer to do, and I'll come back to that. And then you just go higher up and you place the kidney intra-abdominally. Then still, how it needs to sit is determined by the anatomy and also by the kidney itself. So a kidney is not a kidney. A kidney looks almost all the same, but actually, if you look at it in detail, kidneys are very different. Where the arteries go in, how many arteries there are, and how the veins come out of the kidney and how many veins there are, might determine as to where you can connect them to the patient's blood vessels. And of course, since people are so different, the blood vessels of the recipient might also be different in terms of the size and the shape and how they run through your body. So in the end, it all is determined basically by all these factors. And I've placed kidneys in the most weird places. And sometimes it could be that, of course, you feel the kidney and you can even see the kidney. This could be if the recipient is very slim and the kidney is extremely large. Then you can transplant them fine and you can close the skin hopefully fine. But then if you look at people or patients, you might see a little bulge, which is the new kidney. There's nothing wrong with that. And it might be that is determined by the position that the kidney wants to sit in to get optimal blood flow and blood coming out of the kidney in order to prevent any issues. So it is not just by the likes of the surgeon, it is because of good reasons. And normally this is anatomy of the kidney blood vessels and the anatomy of the patient and how many transplants there are there. I promised to get back, Dee, to the fact old transplants, so transplants that might have unfortunately failed after an X number of years, hopefully. We normally try not to do graft nephrectomies, as we call that operation, unless it is really necessary. Because it could be that if you take the kidney out, first of all, it's sometimes a horrendous operation because everything is very stuck down. After years and years of having a transplant, it really sort of becomes, a part of your body. So it is all, there's lots of scar tissue around it, and it could be completely stuck down, which is, could be technically very challenging if it's stuck down onto the blood pipes in the iliac fossa, for example. For it to come out, you really then have to be very careful, and it could be an operation with quite some blood loss. So if you don't need it, don't do it. And the second thing with that is if you remove, for example, a rejected kidney that doesn't work anymore, it could be that antibodies against various types of tissue types, so various types of HLA, for those who are knowledgeable about the tissue type nomenclature, those antibodies might actually come out of the graft but end up in the blood circulation, and that means that you're less likely to find a right match for a next transplant. So there's all kinds of considerations, but in general, the rule in surgery is if you don't have to do something invasive or potentially difficult or potentially dangerous, don't do it. And that's why we have two ideal places. We have an iliac fossa on the right, an iliac fossa on the left. So we always will try to put the kidneys there. And if it's really the only possibility to go back to an old fossa that had been used before, but the kidney is still there, we sometimes will remove a previously transplanted but failed kidney in order to get you transplanted again.
Thank you. Mark also asks, did you take any footage or pictures you can share?
So I'm almost assuming that Mark is one of my transplant patients, but we'll discuss that further in the clinic if needed. In general, I can answer this there's very strict guidance and guidelines and moral codes for this. So first of all, if I take pictures during an operation, this is with explicit consent of the patient. So it could be, of course, very valuable. And sometimes people wish to see their kidney that they're going to get from their brother or loved one. And sometimes people want to see what kidney did I donate. In case of live donation, of course, this can be planned. So if people ask me, can I have a picture, please? I will do that with their consent. If you take pictures of a patient during operation because you find something extraordinary, interesting for students or surgeons in training that you wish to share during educational sessions, of course you can. But what you then need to do is after the operation, explain that something really interesting for future generation surgeons came by. We took some pictures of that. We show that to the patient if they want, and then get their consent to actually use them. If they don't consent, honestly, I never came across people who didn't want to participate in educating the next generation. But should people feel very strongly, of course, you cannot keep them on your camera. And you have to destroy them. And if you want to use them on social media, then you have to get a specific content for sharing any footages or or images online or in social media. And you have to make sure that there is no patient identifiable items there. So it has to be a pure technical picture without the face or, anything that would give up their identity potentially for those who know them. Very personal tattoo or things like that. So very strict rules for that. I must say, I find it very good that these rules exist. It protects people from, being sitting on cameras without knowing that you are photographed, or if, for example, the BBC comes by and wants to film an operation, it really needs to be carefully prepared with the patient or with the living donor. And you need to, get consent for everything you do in that regard. So I'm personally very strict in adhering to that, and also to educate my trainees and fellows on this topic.
Thank you. Tamara asks, are there specific exercises that can be done to improve muscle tone stroke meshing in the area overlying the transplanted kidney?
Yeah, it's a very good question. First of all, Tamara, I think, also on a personal level, I think exercise is massively important, and something that I would recommend every transplant patient to do. The exercises you can do are, of course, various. In general, we normally advise people not to exercise in the first 6 to 8 weeks after a transplant or after a living donation. Just so that the tissues underlying the skin, so these are normally muscles, and the stronger part of muscles called fascia, they need to heal more properly. So even though the skin might be healed completely, and you only see the scar, the tissues underneath that are overlying the kidney are equally important to heal. So if they don't heal properly, and if you start, doing sit-ups and all kinds of core and abs work before that time, it actually might result in a weakness of the wound on the inside, and this might cause a hernia to develop. So a hernia is basically an incisional hernia. So that is a hernia that is developing in the wound. And obviously, that can always happen. And normally there's about 3 to 5%, I think, lifetime risk for kidney transplant patients to develop a hernia based on a weakness. This could be because of a wound infection, or indeed less strong tissue, or impaired wound healing because of prednisolone that you're taking, because of immunosuppression that you have to take, because you're diabetic, because people smoke, because people are obese. These are all sort of risk factors for a hernia from developing after kidney transplant. In general terms, once the healing is done and dusted, and normally get advice from your surgeon if you want to know specifics, then it should be good enough to start exercising. And I always recommend getting a professional there, so either a physiotherapist that knows how to work with people after surgery or even after kidney transplantation, or a personal trainer with some specific knowledge that you can work with to slowly build up again. I think the principle is always start slow and don't start at your old level. If you go to the gym and start at the same level as you were working before, it might actually be counterproductive, and it might cause you more harm than benefit. There's no real specific exercises, to my knowledge, that would strengthen those muscles overlying the kidney transplanted area. But always just get professional advice on that. And this is definitely not my profession. I'm not a personal trainer. I really have to work with my personal trainer very hard, which I do. But I don't know of any specific exercise that would strengthen the muscle tone, which is, of course, very important. We always try with a kidney transplant to not cut too much muscle and to stay in certain anatomical planes that would avoid us having to cut muscles. because I do believe that indeed bulging of muscles, because they lose their normal tonus, can actually result from using a different path during your incision and your way towards this iliac fossa to put the kidney transplant in. But sometimes it is unavoidable. And this is something, it's not done on purpose, but the kidney has to sit in a specific way, and the kidney will have to work, and we do everything to make it work. So sometimes, indeed, people will have some bulging of the muscle, or it can be perceived bulging, but it actually might be just a very big kidney sitting safe and sound on the very strong muscles after transplantation, as I was just alluding to. So hopefully this answers your question. There's no specific exercises, to my knowledge. There's no new techniques to minimize bulging. I really am an advocate of a muscle-sparing incision technique that I'm using, and I don't believe in massive incisions to do a kidney transplant. I always try to minimize surgical trauma, but you can only do that as a surgeon if you still have the best exposure for your transplant to be successful. So we should not compromise the safe transplant outcome and a good transplant outcome just because we're just trying to make the incision so small that we run into trouble because of that. So many aspects, but these are hopefully some answers to your question.
Fantastic. Thank you. Well, I'm going to end with a fun question, which was inspired by Nikki. And this question is, if you're in surgery for like 20 hours plus, how do you go to the toilet?
Yeah. Well, we're all human beings, and surgeons might have believed in the past that they were supernatural or whatever. We're all people, and we all need to go to the toilet. And but surgery is all about being prepared. So this includes you need to make sure you have eaten something, and you need to always be ready to operate. So it's like an athlete. If you have to perform, you need to take a few steps in order to get ready. And everyone has their own little routine. It's quite fun to see because many colleagues have their individual routine. Some people always do things in the same way. What I do is very simple. Right before I start an operation, I just go to the toilet in order to avoid me getting stressed that I have to go to the toilet during surgery. The good thing is, and the bad thing at the same time, is that we cannot drink during an operation. So my longest operation, and I think we covered that in the past, in the previous podcast, was about 27 hours. And this, of course, is an abnormal situation. In this case, it was a very complex liver transplant. Normally, kidney transplants last between 2 and 4 hours. So rarely you're operating for more than 4 hours in a row. It might be that you have multiple transplants to do and lined up after each other. But normally in 4 hours, we can manage if you've emptied your bladder, etc. Before you start to operate. Without drinking, it's very highly likely that you don't need to go to the toilet. But obviously, sometimes you really get thirsty and unfortunately you can't drink. But in all honesty, during operating is so concentrated that it's all, even if there's music around, music doesn't make you pee as far as I know, but it's all about the operation. And if there is an instance, I think it happened to me once or twice in all these years, that I really had to go to the toilet and I had to de-scrub. And you can still, of course, pick a moment where no crucial steps are being made, and you can leave for 5 minutes to go in and out, but you have to scrub in again and sterilize again and do all the steps again as you would before a new operation. So it's we're all human beings, as you can imagine. I always make sure I've eaten something beforehand, because you never know how difficult it's going to be and when your next possible meal or even a bite could be. So It's all about being prepared. And yes, surgeons go to the toilet as well.
Thank you so much. Thank you so much, Dr. Frank, for answering all of the podcast listeners' questions and also a couple of others that were thrown in as a surprise. It's been an absolute pleasure interviewing you today, and thank you so much for your time.
Likewise, Dee, and thanks for sharing all these announcements and to get questions from actual patients, because we can talk from my perspective or your perspective, but the true value, I think, of these podcasts is that we get questions that they always have wanted to ask but don't dare to ask, or have asked before and never got a real answer to it. I'm just hoping that this is another opportunity for people to learn a bit more about their journeys. That's my passion. So delighted to keep doing that. So send all your questions, and I'm sure we find appropriate people. Dee's network is growing every second. So, and Kidney Care UK will absolutely facilitate this to, maximize patients' opportunities to get the best healthcare. I think this is my passion, and I'll do anything to help. So delighted.
Thank you.
Thank you.
Thank you for listening to Diary of a Kidney Warrior podcast. For updates and news, follow me on social media using the handle Diary of a Kidney Warrior. New episodes of this podcast are released every other Monday. Until next time, take care and choose to live.